The hidden side of hernias, diagnosis, risk, and when not to operate. For many, the word hernia conjures images of a painful bulge requiring immediate surgery. Yet, as recent discussions highlight, the diagnosis and management of hernias are far more nuanced than commonly perceived. This article delves into the core definitions, diagnostic complexities, the body's healing capacities, the role of external support, and the evolving discussion surrounding surgical intervention versus watchful waiting, including surprising systemic factors that can contribute to abdominal wall weakness. What is a hernia, really? At its essence, a hernia is defined by a defect or abnormal opening, a hole, in the muscle or facial wall of the body, through which an organ or tissue, most commonly a piece of intestine or fat, protrudes. The visible or palpable bulge is merely a symptom or a physical sign. While almost all hernias present with a bulge, it's crucial to understand that not every bulge is a hernia. Other conditions like fatty tumors, lipomas, swollen lymph nodes, a cyst, muscle strains, or general abdominal laxity can cause bulges. The key diagnostic differentiator for a true hernia lies in the presence of that fundamental hole and the protrusion of contents through it. Diagnosing the invisible, touch versus technology. Traditionally, a hernia diagnosis heavily relies on a thorough physical examination. Surgeons and primary care physicians often palpate the area while the patient is standing, or in different positions to assess reducibility. Ask the patient to cough or strain, Valsalva maneuver. This increases intra-abdominal pressure. If a true defect exists, contents are forced through it, creating a distinct, localized impulse or push that the clinician can feel at the site of the opening. This impulse is a primary indicator of a structural breach, a hallmark sign distinguishing a hernia from other causes of bulging. Assess reducibility. Can the bulge be gently pushed back into the abdomen, or does it spontaneously recede when the patient lies down or relaxes? Reducibility indicates that the contents are passing through an opening but does not mean the opening itself is closing. However, a physical exam alone cannot directly visualize the hole or microscopically assess the fascia's precise integrity. This is where imaging modalities like ultrasound, CT, or MRI become invaluable. These technologies can provide real-time visual confirmation of the defect and the protruding contents, especially in cases where the physical exam is inconclusive due to obesity, a very small or occult hernia, or atypical symptoms. Weakness versus defect. Can fascia heal itself? A significant point of discussion revolves around the difference between generalized weakness and a full-blown defect in the fascia, and how this impacts the potential for natural healing. Weakened fascia, without a true defect or hole. Fascia, the tough connective tissue providing structural support, can become thinned, stretched, or degraded at a microscopic level due to age, genetics, or repetitive strain. This can lead to a general laxity or a subtle, diffuse bulge without a clear, defined opening that allows distinct protrusion. In this scenario, where there is facial weakness or laxity but no definitive, discernible hole through which tissue consistently protrudes, addressing the underlying causes absolutely can lead to the bulge resolving or healing in the sense that it no longer appears. This might occur through strengthening surrounding muscles. Improving core strength can enhance the containment of abdominal pressure and reduce outward bulging. Lifestyle modification, avoiding straining activities, e.g., managing chronic constipation or cough, reducing heavy lifting, can reduce stress on the weakened area, allowing it to potentially recover some resilience. Addressing systemic factors and electrolyte imbalance. Patients with chronic diuretic use, particularly those with congestive heart failure or long-standing hypertension, are disproportionately affected by persistent electrolyte imbalances, such as low potassium, magnesium, and calcium. These imbalances directly impair muscle function and tissue integrity, accelerating muscle loss, sarcopenia, and weakening the abdominal wall fascia. This contributes significantly to generalized weakness or laxity rather than a true facial defect. In early-stage cases, where a bulge represents a weak spot without a definitive hole, optimizing electrolyte levels and correcting these systemic imbalances can improve muscle function and abdominal wall strength. This improvement may lead to the bulge resolving or becoming less prominent, potentially avoiding surgery altogether. Such an approach is especially important given that surgical repair carries a complication risk reported between 10 to 15%. Natural remodeling. The body's natural processes might reinforce areas of thinning, especially if the constant outward stress is reduced. In these cases, the bulge might become less prominent or disappear entirely, and associated discomfort may resolve, often without surgical intervention. The progressed defect, true hernia with scarring. However, when this weakness progresses to a discernible hole or defect through which tissue consistently protrudes, the medical definition of a hernia, the body's repair response kicks in. Fibroblasts will lay down new collagen fibers around the edges of this structural injury, forming scar tissue, fibrosis. This scar tissue attempts to stabilize the area but typically does not regenerate the organized, elastic fascia required to bridge and close the hole on its own, especially under constant internal pressure. Thus, for adult hernias with a confirmed defect, spontaneous healing is generally not expected. Unlike umbilical hernias in infants, where developmental closure can occur, adult facial defects tend to persist and often enlarge over time. Hernia truss, a supportive measure in conservative management. A hernia truss is a supportive garment designed to apply external pressure to keep a reducible hernia or bulge contained. While traditionally considered a temporary measure before surgery or for patients unfit for surgery, it plays a more active therapeutic role when the treatment approach is non-surgical and focused on addressing underlying root causes. In such cases, such as patients with abdominal wall laxity due to systemic electrolyte imbalances, muscle weakness from chronic diuretic use, or early-stage facial thinning without a true defect, a truss provides essential mechanical support, reducing strain on the weakened area during movement or daily activities, and alleviating pain and discomfort by physically keeping the abdominal contents inside. This prevents the stretching of surrounding tissues and pressure on nerves that cause symptoms when the bulge protrudes. Prevents progression to a true defect. By continuously supporting the area and preventing the bulge, a truss reduces the mechanical strain on the weakened fascia or the edges of an existing defect. This can be crucial in preventing further mechanical degradation or enlargement that constant outward pressure would otherwise cause. Allows the fascia and musculature time to stabilize or improve, especially when coupled with efforts to correct electrolyte imbalances, improve core strength, and avoid high intra-abdominal pressure. This can be particularly vital when a bulge is caused by generalized weakness or muscle laxity, without a true hole. By preventing the bulge and its associated strain, the truss gives the body the necessary time to potentially strengthen itself through exercise, or for underlying systemic issues, like electrolyte imbalances, to be addressed and take full effect. Since these internal healing and strengthening processes are not instantaneous, the truss serves as a beneficial tool during this interim period. In these conservative cases, a well-fitted truss may be necessary and therapeutic, not just palliative. However, it's still crucial to observe the following precautions. No healing of structural defects. A truss does not close an existing facial hole. If a hernia is confirmed, the truss does not cure it, but may temporarily contain it. Ensure full reduction before use. the bulge should be completely reducible before applying a truss to avoid trapping tissue and masking signs of incarceration. Monitor for discomfort or skin issues. Long-term use may lead to chafing, rashes, or discomfort if not properly managed. In summary, while not curative in the presence of a confirmed hernia, a truss becomes a valuable part of the healing strategy in patients undergoing non-surgical management for systemic or early-stage facial weakness, offering both protection and time for underlying correction to take effect. The complex decision: surgery versus watchful waiting. Given the risks associated with surgery, including chronic pain, the question of necessity is paramount and involves a nuanced risk-benefit analysis. Surgeons weigh several factors. Symptomatology: if the hernia causes pain, discomfort, or limits daily activities, surgery is often recommended to improve quality of life. Hernia characteristics: larger hernias or those with wider defects may be more prone to complications and sometimes more challenging to manage conservatively. Risk of untreated hernia complications: the most significant concern is the unpredictable and potentially life-threatening risk of incarceration. Hernia contents get stuck, and strangulation, blood supply to trapped contents is cut off, leading to tissue death. Elective surgery, performed in a controlled setting, carries significantly lower risks than emergency surgery for these acute complications. Patient factors and systemic contributors to weakness. Lifestyle and occupation: patients with jobs or hobbies involving heavy lifting or strenuous activity are at higher risk for hernia progression and complications, making surgery more advisable. Factors like chronic constipation or coughing, e.g., from smoking, asthma, also contribute to increased abdominal pressure. Overall health and underlying conditions: for very elderly patients or those with severe comorbidities, e.g., significant heart or lung disease, the risks of surgery might outweigh the risks of watchful waiting for a small, asymptomatic hernia. Electrolyte imbalances. Critically, systemic issues like chronic electrolyte imbalances can contribute to generalized muscle weakness and overall abdominal wall laxity. Patients with conditions like heart failure or hypertension, often on long-term diuretics, are particularly susceptible to imbalances in potassium, sodium, and magnesium. While correcting these imbalances will not close a true facial defect, optimizing electrolyte levels can improve overall muscle function and potentially reduce the prominence of a bulge if it is due to generalized weakness rather than a discrete hole. Importantly, in patients who notice a small, early-stage bulge, especially those on chronic diuretics, it's worth exploring whether the issue stems from systemic muscle and fascia weakness rather than a structural defect. In such cases, addressing electrolyte imbalance and supporting muscle health may be enough to reverse or stabilize the condition without surgical intervention. This non-invasive approach could prevent exposure to surgery-related risks and complications, provided there is no evidence of a progressing or symptomatic hernia. Patient preference and risk tolerance. The ultimate decision involves shared decision-making, where the patient's understanding of risks and their personal priorities are central. Watchful waiting, active surveillance, is a recognized management strategy for carefully selected patients, typically those with very small, asymptomatic hernias that are easily reducible and who have no lifestyle factors that significantly increase risk. This involves careful monitoring for any changes or new symptoms that would then trigger a recommendation for surgery. Patient perspective: understanding the numbers. Patients often encounter varying statistics regarding surgical complications, particularly chronic pain. While some research indicates chronic post-hernia pain rates of 10 to 15%, encompassing any degree of persistent discomfort, experienced surgeons often report much lower rates, e.g., 1%. This discrepancy often stems from differences in the definition of chronic pain, any pain versus pain requiring ongoing management, surgical techniques, and the surgeon's personal expertise. Similarly, the annual risk of a hernia causing a serious complication like strangulation is often cited as low, e.g., 1 in 500 or 0.2% per year for certain hernia types, but the cumulative lifetime risk is higher. These figures underscore the importance of a transparent discussion with your surgeon, clarifying their specific outcomes, the lifetime risk of your particular hernia, and how your individual health profile and lifestyle influence the risk-benefit analysis. Conclusion. The journey from a bulge to a hernia diagnosis involves careful clinical assessment, often augmented by imaging. While the presence of a hole defines a true hernia, the decision to operate is a complex, individualized judgment call. It balances the potential, though often low, risks of elective surgery against the unpredictable, but potentially severe, risks of leaving a hernia untreated. Understanding these nuances, recognizing potential underlying systemic factors like electrolyte imbalances, and engaging in thorough shared decision-making with your healthcare provider are paramount to making the best decision for your health.